They've passed all of our courses, clerkships, clinical rotations, and promotional OSCEs. They've done their capstones and research projects. So it's July, day 1 of internship. 9 new interns have just started and 2 are assigned to clinic. They both came from good medical schools. They both passed their STEP exams, and they're both eager and ready to work. The chief residents have their own full panels. The second years have the week off, and the third years are covering the ICU. The attending has to decide. Can I send this intern on his own to evaluate Mrs. Gordon, whose chief complaint is a worsening tremor? Or can I send this one to evaluate Mr. Cuervo, who has suboptimal blood pressure control? Unless that attending worked with that intern as a medical student, she won't know what that intern can do until she can observe the intern performing each core skill. The truth is that attendings on day 1 of internship just can't be sure of what these new trainees can be trusted to do without direct supervision. This uncertainty, faced every July in every medical teaching institution, has supported a long-standing perception that July is the worst month to receive care in a teaching hospital, a perception that in fact has been the subject of many studies. In fact, a 2011 systematic review, published in the Annals of Internal Medicine, looked at 39 studies that examined if patients do indeed suffer because of the July effect. Among higher quality studies, it found significant increases in July mortality rates, as well as other adverse outcomes in medical errors. Another perspective is that of the gap, the difference between the skills medical students are graduating with and the skills that residency faculty expect them to have on day 1 of internship. The American Association of Medical Colleges recently asked residency program directors whether they were confident that all or most of their new trainees could do the following. Only 66% agreed that all or most of their incoming interns could prioritize a differential diagnosis following a medical encounter or recommend and interpret common diagnostic and screening tests. Only 55% of them agreed that all or most of their new trainees could perform a patient handover responsibly or recognize a patient requiring urgent or emergent care and initiate evaluation and treatment. This survey, done by the NBME, takes another important perspective. It asked interns what they did in the first year and whether they did it with or without attending presence or involvement. Results showed that interns were commonly performing complex elements of clinical care early in the training year and sometimes without attending involvement. The authors concluded that their own study, as well as others, support the claim that adequate supervision is sometimes lacking. So what's the solution? Can attendings provide more supervision? To some degree, yes, but can patient volume be adjusted downward? Perhaps in clinics, but not in hospitals and ERs. But what about those of us teaching medical students? What can we do to ensure that at least for some elements of clinical care, every group of interns is a group of trainees with a known set of skills? After all, we admit a selective group of very talented and intelligent young adults, and we have 4 years of their formal education. As medical school faculty, we should be able to reliably deliver graduates with some set of important abilities. So in response, the AAMC convened a drafting panel to develop this document, published in the spring of 2014. It outlines 13 core entrustable professional activities, units of work, that the drafting panel agreed that all interns should be able to do without direct supervision, which means without the supervising physician physically present with the resident and the patient. Of course, some form of indirect supervision is always required for residents, whether that is immediately available supervision or off-site supervision. These are the 13 EPAs. Bear in mind that these are summative statements only, giving you the essence of the activity. To perform each one competently, a student has to learn, apply, and practice substantial bodies of knowledge, skills, and attitudes. Some of them, on first glance, look like what medical school has been teaching quite well for years. Yet even within these, the bar might be higher than some of us would assume. Some of us trained when doctors did not think about cost-effectiveness of tests, for example. We might not have been asked to explain in a written note how we got to a diagnosis or plan, or where our reasoning and plans had unresolved ambiguity. These CPAs draw on newer elements of medical education that are truly core abilities for participating effectively in 21st century healthcare. Each EPA has critical functions, designated here by the bullet points for the EPA on obtaining informed consent. They outline the knowledge, skills, and attitudes that are required to perform the activity so that direct supervision will not be necessary. There are also 2 vignettes for each EPA, one describing a pre-entrustable learner, that is the learner who still needs direct supervision, and another vignette describing the entrustable learner who does not need direct supervision. Let's take the example of EPA 5, documenting a clinical encounter. You're reviewing a student's admission note on your patient Griffin, a 3-year-old with cystic fibrosis who was recently discharged after treatment for pneumonia and failure to thrive. You spoke with his mother yesterday by phone when she was calling about his refusal to take the nutritional supplement prescribed, and then again early this morning when you decided that she should bring him into the ER for persistent cough, poor oral intake, and listlessness. The chief resident and the ER attending took care of the formal admission, but you've asked Mina, the 4th-year student, to do her own note without any input from the chief or the attending so you can assess her skills. Mina is a pre-entrustable learner. You find that Mina's note has a date, but no time or signature, has the chief complaints, persistent cough, poor oral intake, and listlessness, but it has no mention of important related symptoms, such as urine output or a pattern of bowel movement, abdominal pain, and fever. It includes an inaccurate medication list, clearly copied and pasted from the last discharge summary. Labs are listed as within normal limits, but without dates and times. And it includes a poor plan for nutrition advising to continue the same supplement Griffin has been refusing. On the other hand, Becca is an entrustable learner. Her note has all of the information that Mina's note was missing, and more. It includes the results of the chest x-ray and sputum cultures during the last admission, showing bilateral infiltrates and the Pseudomonas infection. A clear differential diagnosis for each problem, with orders for each problem, orders for IV fluids, and a nutritional consult to resolve the issue with the supplement. And she brings to the chief resident her questions about the possibilities of revising antibiotic therapy at this time, and any special precautions that might be necessary in a case of suspected antibiotic resistance. Finally, she notes that Griffin's mother brought up the same issue with getting home care services that another patient described, so she lets the resident and the attending know about a possible systems problem with communication with the agency. In essence, Becca's demonstrating the 4 elements of entrustability, the questions every attending asks every July to determine whether a trainee can be trusted to perform an element of clinical care on his or her own. First, she has the abilities, the knowledge and skills, to think through the case, do the required evaluation, and come to a diagnosis and plan. Secondly, she is truthful. She records only the information she has verified. Thirdly, She is discerning. She knows the limits of her own knowledge and asks for help. Finally, she is conscientious. She obtains accurate detail, takes responsibility for identifying areas of her own uncertainty, and identifies a possible problem with the function of the system. So now there is work to do. Each medical school needs to decide how it is going to make sure all students have sufficient opportunities to develop these abilities, and most importantly, devise a system for determining whether they have indeed achieved the level of the ability necessary to be entrusted. This means that all faculty who contribute to the clinical education of students have to focus on what we do to first help students learn these skills, and secondly, on the feedback and assessment we can provide to help determine if indeed they are entrustable. Florida International University Herbert Wertheim College of Medicine is proud to announce that we have been selected as one of 10 U.S. medical schools to test the implementation of the EPAs. This project will help us accelerate our work with the EPAs, and it will allow us to learn from other schools and contribute at the national level on the best approaches and tools. Our success will require further development of the best elements of our existing program. But perhaps the most important of all will be the contributions of you, our clinical educators. You are the ones who will help us maximize the opportunities to learn to do these activities, and most importantly, the opportunities to determine how much a student can be entrusted to do. We are starting with a survey of our students to estimate how often they are observing and/or participating in the critical functions of the EPAs, and we're taking a detailed look at our in-house teaching to see where we're doing some of the teaching and assessment in classrooms and neighborhood help. We'd like you to take the same survey, linked at the end of this video, to get your perspective on how your own clinical setting is contributing, or might contribute more, to the learning and assessment of student abilities. We welcome all questions and comments you may have about the EPAs and all other aspects of our curriculum. Thank you.